Welcome to the JOMA Preventative Health Podcast, hosted by the Jewish Orthodox Women's Medical Association. We provide you with up-to-date information on health topics geared towards the Orthodox Jewish community. This podcast content is provided for informational purposes only and is not intended as medical advice or as a substitute for the medical advice of a physician.
Welcome to the Jewish Orthodox Women's Medical Association, or JOMA podcast. I'm your host, Elisa Minkin. I'm a general pediatrician and proud JOMA member. And I'm really honored and really excited to be interviewing Dolores Laskin. Before I go into Dolores's bio, I'm going to just say, as I've been doing lately, that I love it when people who are passionate, knowledgeable about certain areas reach out to me to be interviewed. They can reach out to me on health, HEALTH, at joma.org. Topics I haven't done in great enough depth or haven't done at all. Specific perspectives, please reach out to us. Very interested in interviewing a wide range of people. So Dolores Laskin is somebody I came across and said I must interview her. She is an audiologist and speech and language pathologist, and she also has a significant hearing impairment, which she will talk about. She has over 25 years of experience. She received her education at St. John's University and has an extensive background working with children with receptive and expressive language deficits, feeding issues, hearing impairment, and using of assistive technology, articulation, phonological deficits, and childhood apraxia of speech. She is trained in the SOS approach to feeding and is PROMPT certified. PROMPT is a method used for speech apraxia. She has worked for the New York City Board of Education and a private special education school serving children with communication delays on Long Island, as well as in private practice. She is currently the Director of Related Services at MKSA, as well as being an adjunct professor at Stony Brook University. Welcome, Dolores. Thank you so much for joining me tonight.
Oh, it's my pleasure to join this evening.
Yeah, no, I'm really excited about this. We've had fantastic conversations, and I think we're going to have another one tonight. So as I told you, I already interviewed an audiologist. I interviewed an ENT, actually interviewed a developmental pediatrician where we focused on speech delay as well. But you're giving us a new perspective because you have your dual certification in speech therapy and audiology. You work exclusively with children, correct?
I do some older, younger adults as well, but primarily it is children.
Right. Because some people do adults and children, but really their main thing is adults. In your case, it's kids. It's kids, which is good because that's my zone. And also you yourself have hearing loss.
Yes, which is what actually brought me to this field in the first place, because when I was 7 years old, I was picked up on a hearing screening that I was hearing impaired, and my parents went through what most people go through when there's a diagnosis. You send for genetic testing and genetic counseling, and the parents can't really believe it. And I remember my dad, when they took me to a few audiologists, and he would say, don't tell them anything was wrong. In other words, he was trying to say it was some sort of glitch, or they were, somehow they were doing something that was showing up, which made no sense at all. But there are these feelings that go on with parents, knowing that there's something wrong with their child, no matter how big or how small. And when I walked out of the audiologist's office for the last time at that age, I turned around and I said to my mother, I said, this is what I'm going to do for a living. And I was 7. And my mother said, okay, kind of blew off the whole 7-year-old. What does she know? And when I started my my in-depth look at colleges after I was finishing high school, and I had already felt what the hearing loss was like for me during those years of schooling, I made sure that that was the path I was going to follow. 6 years later, I come out with my degree in audiology. I get married. I'm in it for about a year. I look at my new husband and I say, I'm going back. And he goes, you're going back? You just got out. And I said, no, I'm going back. I said, there's so much more that I need to be able to do. And I can't just do it as an audiologist alone. I said, I need to go back and get another degree in speech language pathology, I said, and really understand this and really I come from a perspective knowing what those kids go through. I saw what my mother and father went through. And I said, I need to be there for them. And so that's how we ended up here. 2 degrees later.
It's an amazing story, but I don't know how you got to age 7. I mean, maybe you can explain a little bit about what type of hearing loss you have and how obviously there's different types. You're not.
No, I am. No, I'm not deaf. And I will be completely honest that this was happening in the 1970s. Things very different than the way they are now. And so for all that time, they really didn't realize anything was wrong. I always wonder if the fact that my grandparents were living with us, there was everyone always speaking super loudly in the family, may have had something to do with that, that they didn't pick it up so readily. And then when I finally had, that they diagnosed it at age 7, we look back and say, well, what was going on? No one in the family had hearing loss. If you look at the data, even for people that are born deaf, 90% of those people are born to hearing parents. So there wasn't something that, made them think something was going on. I always did very well in school. But I do have permanent hearing loss in both ears, and it's moderate to moderately severe. And it is straight through the, what we call the speech frequencies, 500, 1000 and 2000 hertz. That's exactly where my loss is. I hear better in the lows, I hear better in the highs, but straight through that middle, I have a problem. For some unknown reason, my speech never really got affected. I was definitely born with this from everything that they can, come up with. But for some reason, I have been able to fill in the gaps. I am very good at watching people's faces for cues. I wasn't aided until college. The hearing aids, we've had a lot of development in hearing aids, even in the past 20 years. And the ones that they originally fit for me, they never felt right. I always felt like I was clogged. I hated them. I was one of those people that we call ITD wearers in the drawer. They stayed in the drawer. They didn't really stay on my ears. But I managed. And then in the last few years, another audiologist friend of me said, you have to try the new ones that are coming out. You just have to. And I love the ones that I'm wearing now. But technology has brought us far. And it's funny because the industry that's really driving the technology is the music industry. We've gone analog to digital. I remember sitting in classes back in the early 90s where CDs were just coming out. And they were telling us this was going to be a big part in the hearing aid industry. And now when I look at everything that's going on, I mean, my hearing aids are attached to my phone. I can stream through them Bluetooth. I can pick different programs so that if I'm sitting in a room with a lot of people, I can say, react to background noise. Put it that I'm only speaking to the speaker, that it's going to black out everything else. There's just so many. I'm watching TV and I can put it on a program for that. They're just amazing. And there's so much more that we are able to do that we were just not able to do in the 1970s. And the biggest thing that came about was the fact that we have universal newborn hearing screening,
right,
which was something that really didn't exist when my son was born in 1999. The first thing I said when I was interviewing pediatricians, I said, well, when I give birth, I just want you to know they have to do an ABR. And he looked at me like I was crazy. And he said, why are we doing an ABR? And I said, because I was born with a hearing loss. I said, and he's like, well, it can't be that significant. And that's like my thing. I'm like, any hearing loss is significant. You wouldn't want to be walking around without glasses or somebody drive that car. And so he said to me right away, he said, I want you to know that the insurance probably isn't going to cover it. He said, because he said, there's really nothing to say. I said, well, it's got to be medical necessity. I said, I have a loss. I said, we need to take a look at this.
I'm sorry, when did we start screening newborns?
2000.
Oh my gosh.
2000. So wow. I had just missed it. And my son it actually is December of 1999. So they did an ABR back then, which is different than what we're doing now. And he passed, and I was really excited, obviously. But, we've had this thing in my family for years that if it were going to happen, if I was going to have a child that was hearing impaired, that I was going to be well equipped, because I had done all my research. I met the people in the field I needed to meet with, and I was going to make sure he got, the best of care. But by the time my daughter is born in 2004, I don't have to say a word, because newborn hearing screening is in effect, and I know they're going to screen her. Interestingly enough, even though they screened her, they made sure, and it was at Stony Brook at the time, they turned around and said to me, she's a pass, but given your history, we still want her followed up with an ABR, which I thought was amazing. Because
I just want to stop for just a second and explain the difference between what they're doing now and what an ABR is, just so people will understand.
Sure. So an ABR is more in depth. You're hooking a baby, an infant, up to electrodes, and you're still pass or fail. Usually they did with the ABR as to whether the child is hearing. It bypasses, they're looking for a sensory neural hearing loss, something that can't be fixed. The thing is, now with OAEs, otoacoustic emissions, it's actually just a small probe tube that goes in the ear, and it reflects the actual sounds that the inner ear is making. The inner ear actually reflects back sounds. So it's picking up recordings of those hair cell sounds. If it doesn't pick up enough of the hair cells, the baby fails. So it's much more simplistic than having all these electrodes on. But because of my situation, they said, no, we want you followed up. We need her followed up, which I did. I had no problem with it. I actually went to one of the college's teaching facilities and said, you know what? I worked on everybody else. I want to be able to have the students work on mine. And she passed. I think now that I'm working so much with early intervention children that come in, the thing that I get most is, and it's one of my number one questions is, did they pass or fail the newborn hearing screening? And the parents will say to me, how would I know that? I said, if they follow up with you, then they fail.
Right. It goes in, right.
Information.
Right. It comes in your packet. It should be in the packet.
If you open it.
If you open it. Right. So much is going on. You don't necessarily, the pediatrician must be checking that. Must be checking so and then following up if it hasn't been passed. And there were reasons, I went through this with the ENT, why the OAE or otoacoustic emissions might be failed without there being a hearing loss, because it's external. It could be there's fluid from birth in the ear, for example, or earwax or whatever.
Exactly.
A narrow canal or whatever, like external reasons. The ABR is auditory brainstem response. Is it possible to pass the OAE but still have hearing loss?
Yes. There is a small percentage of children that are missed. A very mild hearing loss could be missed on an OAE. But I also feel that we somehow have lulled people into a false sense of security. Just because you pass the OAEs or the infant passes the OAEs, there's tons of things that happen afterwards that can affect hearing loss. And that's a hard thing. So that, I think they hear pass and say, I'm out of the woods, nothing can happen. Where there are definitely disorders that you have a progressive hearing loss, so that everything looks fine at birth, and then all of a sudden the hearing starts to deteriorate. That's one thing. The other thing is there are so many instances of middle ear pathology, middle ear infections that kids go through. Right now in the United States, 5 out of 6 children will experience some type of middle ear infection by the time that they're 3. That's really high. It's around 83%. So, and when they experience these middle ear infections, there is a chance they are going to have related hearing loss to it. Now, those types of hearing losses are, usually pretty fixable. A round of antibiotics, several rounds of antibiotics. If it's the pediatrician deems it's viral, we're going to wait it out and let's see if it clears on its own. But there are a lot of cases where it doesn't. And parents find
I just want to interrupt as a pediatrician for just a minute. What
Sure.
it means to wait it out. It's not that it's viral versus bacterial. We can't tell. It's that 80% of ear infections will resolve without antibiotics. We've been overusing antibiotics and causing all kinds of problems. So there are criteria, very specific criteria for when you can watch and see if it goes away on its own. That's why.
No, and I didn't mean to say that otherwise,
Right.
as far as the fact that some will be treated and some won't.
Right.
Some will resolve on its own. Some of them won't.
Mhm.
And then those are the parents that end up finding themselves in ENT offices to see if you need to have tubes put in. And, then hopefully things will resolve on their own afterwards. The tubes will stay in. I've heard cases where the tubes are open for a year before they fall out. Some people tell me, oh, nope, ours lasted 3 months and we had to get them put back in. It really depends on the child, where parents find themselves in that situation. But those are the easier ones to conquer, when it's middle ear. And going back to the newborn hearing screening, that sometimes I tell parents, it's not uncommon to get false positives because there's debris in the canal. I said, so don't get excited. Just make sure you're following up. I mean, that's the big thing. And like you said, hopefully most of them have opened the packet, but there's a lot going on at that point.
Right.
That kind of overshadows some things at some times. So we're much more fortunate right now where we are as far as the treatment of hearing loss. Like I said, the ones that are conductive, which are happening in the middle ear and the outer ear, for whatever reasons, can be treated in several different ways, medically, surgically. When it comes to sensory and oral, you're in a situation where it cannot be fixed. Like myself, there's no fix. But we do have hearing aids. Certainly, like I've said, that have really good technological advances. Cochlea implants for those children. When I started in the field, you had to be profoundly deaf in order to be planted with a cochlea implant. Now they're planting kids with moderately severe losses to severe losses. It's a different mentality that we're dealing with. And they're getting implanted sometimes at 10 and 12 months of age, and the testing for it is starting around 3 months. We're certainly, that's 25 years advancement to where we were. And the reason why, those babies getting implanted, goes back to the whole fact of early intervention.
Right.
We want to get that exposure to sound as soon as we can. They're prelingually deafened. So if we can get them earlier and have them go through the process of as close as they can to their peers of language development, that's the best way that we can do it. So it's a big changeover in the way we do things. And even with the hearing aids with the kids, a lot of them going through treatment with speech language pathologists with the hearing impaired are being fit with FM systems. So back in the day when I first started, FM systems were huge. They, much like hearing aids, were a lot bigger than they are now. We are in a time where you can literally, and I'm sitting here with you, my hearing aids are very small. Really, you can't see them. They take almost what you would say as a USB port and clip into the hearing aids, the FM system. So you can't even really tell that the FM system is on a child with hearing aids. And then, yes, the speaker, whether it be the teacher or the SLP, is wearing, a microphone, but even that much smaller than we used to give people 25 years ago in order to improve that signal to noise ratio.
Right. Let me just have you explain just really, so it's really clear what do you mean by an FM system? You're talking about somebody, a child who has hearing loss, who's already wearing hearing aids, but you also want to have the speech from the person speaking go directly into the hearing aid rather than be dissipated surrounding noise, like in a classroom where there might be a lot of other sounds that might be harder for the child to filter out. Correct.
So it improves your signal to noise ratio and it makes it directly into your ear. So if for a child that's learning, a recently aided, even children who are not aided, who might have a conductive hearing loss, but the conductive hearing loss is long-standing, these children can be fit with FM systems. Now, in the case where if you're not wearing a hearing aid and you're not being booted in, quote unquote, with the FM system, they wear them like headphones. And the kids are so used to it nowadays. It's not really a big, I think it was a bigger issue years ago, just like I think hearing aids were bigger years ago. Now everybody's got something in their ears because they're walking around with AirPods.
Right.
I don't feel so out of the loop anymore.
Yours are much smaller than those AirPods.
It's true. It's true. But everybody, you don't want to look different. You don't want to look different. That was a big thing for kids, even now, obviously. I think it's a big thing for parents. I had one experience where I was working with an infant. I worked him just under 3 years old. The parents actually moved off Long Island, but the nanny was with the child during the day, and that's really when I was in the house working with the child. And I said something about them going to the park, and the nanny goes, "Oh, well, when I take him, he's wearing them." He goes, "But I know when the parents have him on the weekends, he's not wearing the hearing aids." And I
ITD.
Yeah.
Yeah.
I'm like, why wouldn't they? She's like, they don't want him to look different than anybody else. And like, my heart broke because I'm like, what a disservice. You went through all you did to the testing, get the child fitted, got early intervention services. I'm in here doing speech. They really didn't understand that there's incidental learning going on practically 24 hours a day. I mean, if the child's up for 19 hours, they are listening to not only their parents and their teachers, but other children are teachers in life. And if you and I also worry about safety reasons. When you have kids on playgrounds, etc., and you don't have them aided, the localization of sound and where danger can be coming from. It's just really, really important. And, a lot of what we do as speech language pathologists and audiologists is counseling. After we fit them, after we're giving them the speech therapy, it's this idea of that learning takes place all the time. So, even if we only have a child with us a half an hour, 45 minutes, 2 or 3 days a week, we need you to take whatever we're teaching, whatever you're watching us do, and implement that when we're not there. And it's really very important and a big piece of what a lot of us do all, every day that we're working with the kids. I think that getting back to the fact of the newborn hearing screening, what do we do about the kids, or how do we identify the kids that weren't picked up on the newborn hearing screening when it's mild, or they've got some sort of progressive loss that we didn't. The big thing that comes out is them not startling to sound. So it was very funny. I had a phone call several years ago by a physical therapist, and I said, she's like, "Dolores, bear with me on my phone call." I was like, "Sure." I said, "What's the matter?" She said, "I'm seeing this baby for torticollis." I said, "Okay." She said, "Mom said that the fire alarm went off in the house and the baby didn't startle." She said, and Mom said, "Oh, but the baby's a really deep sleeper." I go, "A fire alarm."
Wow.
Think how loud a fire alarm is. I said, nobody who's a deep sleeper is going to just sleep through a fire alarm. Something is going to jar you if it's a fire alarm. So she said, "So you don't think I'm crazy?" She said, "Because I'm recommending that we do an audio." I said, "I don't think you're crazy." I said, "Not in the least." I said, "You really need to follow up on that." Make a long story short, the child had a significant hearing loss. And that's why I didn't, startle to the sound. So when parents come in, I said, if it's a significant enough loss, they are going you're going to have a problem with that baby startling to a loud noise, like a fire alarm, like a really loud doorbell, something along those lines.
Right. But the flip side would be you could have a significant hearing loss and still react to those things.
Correct.
Right. I mean, nobody knew you had a hearing loss until you were 7.
Correct. But mine isn't where I think what she was worried about, and rightly so, was the idea that this was profound because the baby wasn't startling. But in my case, I would have startled because I'm a moderately severe loss. I'm still going to startle, and I'm trying not to get off track, but people with hearing loss have an abnormal growth in loudness. What does that mean? It means that I'll feel the pain of a loud noise or concert much easier than somebody with normal hearing. So it's kind of like an oxymoron because you're like, well, wait a minute, you're hearing impaired. So it's a phenomenon called recruitment, and it's an abnormal growth in loudness. So what happens is if the
abnormal
growth in loudness.
Growth
in loudness. So what happens is if I have part of my cochlea damaged, which I do, those hair cells are damaged, what the other hair cells, they'll try to recruit the other hair cells to hear what's going on. So the more they're recruiting those hair cells, the louder things are going to be. So what happens is if I'm at a concert, well, there's lots of reasons to be wearing ear protection at concerts. But the idea is not only that, but to me, it might be louder than for my husband who has perfectly normal hearing. So one thing that my parents were not aware of, and then later on, looking back, they were told, they said, does she have any problems with loud noises? And my mom could not fathom, but my brother's 10 years older than I am. And we happened to be at his high school graduation. And when everybody was clapping, she realized I was cowering in my chair, that it was so. But if somebody hadn't said to her that that was a sign to be watching for, that loud noises would actually bother me more than somebody else, she wouldn't have known it.
Right. You might think that's a sensory issue. It seems more like a sensory issue.
Absolutely. Absolutely. But if you notice people, and I'm going to go to like the elderly population, which are ones that we usually have the hearing losses. Do you ever notice that they turn around and say, stop screaming at me?
Right.
Even when we're not necessarily screaming. I mean, a lot of times we are, but that we're not really screaming at them. The unfortunate part is it sounds loud to them. And when people are fit for hearing aids, including children, and a lot of it has become more objective now, how we're fitting with hearing aids than say 20 years ago when we'd say to somebody, okay, here are 3 different levels. Listen to them and tell me what's most comfortable for you. This is level number 1. This is level, and you're fitting to what they say is their most comfortable level. The flip side is as an audiologist, you also say, okay, it's getting louder. Tell me when it's too loud. And then you stop. The big problem in fitting, and when I say the audiologists it's an art, is that when you have a person that their most comfortable level of hearing is like 70 decibels, but when it starts to get painful is 90.
Wow.
That's very difficult to fit. You only have 20 dB to play with them before they're going like this, with their head exploding. So it happens. And we've gotten, like I said, much more objective testing out there in order to help have better fits for children and adults, especially the little kiddos that can't tell us when things are comfortable, when they're not comfortable. So it's much easier to do it on objective testing to fit those hearing aids.
Absolutely. So I did talk about hearing loss in the newborn period in my other talks, and you talked a little bit about it here. I think in a way, those are the easiest cases because they're picked up and they usually have a team approach. And that's amazing. You talked a little bit about red flags, but those red flags were really for profound loss. What would be some other reasons you might say we need to get a hearing test, even in a child who passed the newborn screen?
Sure. So obviously a speech language delay. And we talk about speech as in the expressive part of it and the receptive part of it. So in the cases where they're not developing language appropriately, they may have a significant issue with both receptive and expressive because they're not hearing what is going on. I have a lot of kids that we see for hearing tests where they're ruling out hearing loss because there's also a possibility that the child has autism and they want to rule out hearing loss. And I said, interestingly enough, we say that our autistic populations do not have good eye contact. Our hearing impaired population tend to be doing, that in your face almost look at because they're looking for visual cues and some of it has to be taught how to do it, but some of it's instinctive that they're looking at people's faces. So that's one thing. If you find that they're really looking at you, I constantly will tell somebody, can you turn around? I can't hear you. The kids are those kids in class that might be that the teacher, even in daycares, they're calling their names or they're saying something. And often when I'm working, I'll say, do they respond to their name? And the parent might say, no, they don't respond to the name. But then I take it a step further and I say, if you're in another room and you turn on their favorite cartoon, do they come running? My children that I work with that are on spectrum will come running if Mickey's in the other room. My children who are legitimately having a hearing loss won't come running because they can't hear it. They can't hear it. And I have so many parents, and I said, there's something called comorbidity. You can have both going on.
Right.
We have to make sure that there's not something else going on. And so many parents will say to me, nope, never had an ear infection. Nope, never had this. Right. But some kids sit with fluid and they're not complainers. They're not running 104 fever. There's really no reason. They're fine, but they could still have fluid. And so they'll walk out and I'll do, and I'm sure you've spoken to it, especially having had on the ENT, but we'll do a tympanogram, which looks how the middle ear is working. And those kids will come up with fluid and have a subsequent hearing loss. And the parents are like, oh my gosh, I had no idea. I said, you wouldn't. There really would be no reason. I said, unless there was this dramatic change in him not responding, I said, if he's always sat with fluid in his ears, I said, and he's not running fevers, there really wouldn't be any reason. I said, but now that you know, I said, now you've got to follow up. You've got to make sure you're checking this out and making sure that things resolve and the first step is going back to their pediatrician and having it looked at.
Right. How much of a hearing loss does fluid in the ear cause? Because we're not talking about profound hearing loss at this point. No, we're talking mild to moderate. If there's an infection associated with the hearing loss, you could be talking about 50 decibels of loss. If it's just sitting with fluid and it's not infected, 30 decibel, the child will be coming in. So somewhere around that range, in the mild range. So we're not talking, and remember something, hearing loss doesn't have to be in both ears. You've got these kids that one ear is being affected and the other ear isn't being affected. Well, what does that mean? Well, the stronger ear, the better hearing ear is the one that's responding. So you may never know that the other ear is having a problem. When we test the little ones, it's in a sound field. They're not wearing headphones for the most part. And when I come out, I'll say to the parents, okay, hearing is within normal limits in at least one ear. Right.
And then I have to explain to them, the other ear could have some sort of loss. It could be mild, it could be moderate, it could be severe, or it could be completely profound in that ear. I don't know, because the other ear is always the ear that's stronger, is going to be the one that responds in that situation. So, we always tell them, we want to see you again in another 6 months, and hopefully get them on their headphones at that point. If there's really a concern with children that can't be tested by quote unquote traditional methods, we will send them for an ABR. The thing is, when the babies are under the age of 1, it's easy to do an ABR while they sleep. Once you get that they're older and they're moving around and that's when we start saying to parents, well, now we're thinking about sedation. And most parents don't. I'm a parent as well. You really don't want to do that if you actually really, really have to. The great thing about otoacoustic emissions is they're used as part of most of the evaluations being done. So if you can get, again, depending on the child, they have to be quiet and still for a certain amount of time in order to do the OAEs. That's why it's easier when they're younger than when they move into the toddler age. But if we can get those tests and put all the information together, we get a clearer picture. And sometimes it's just not one visit to the office. Sometimes it's several visits. And I always tell the parents, relax. We're used to this. I'm doing this 27 years. Sometimes we get it on one, sometimes we get it on two, sometimes we need three. I said, it's fine. I just want the most appropriate picture of them and make sure that we don't miss anything.
Right. What's the importance of unilateral hearing loss? I think, well, you have one good ear, who cares?
A lot. So one is that having both ears means you could localize to sound. Once you take one ear out of the picture, your ability to localize sound is that much poorer if you can do it at all. The other thing is, and people don't realize, is that having two ears, even if we're in a situation where we're talking, say, at a restaurant, one of the ear's jobs is actually to suppress the sound. It makes no sense. But one ear focuses in while the other ear kind of depresses. So you lose that ability. When we always used to say, speech language development will be perfectly fine if you have one ear, but it's not true. And we find a lot that kids with unilateral hearing losses are those who have significant learning disabilities in the classroom. So it's not you're going to develop like everybody else if you have one good ear. The research and the data is supportive of the fact that you really need two good ears. So that's why it's important as soon as you can to get the child under headphones so that you can get each ear isolated and find out what's going on.
Right. This might be a really stupid question, but with eyes, it really matters that if you have one bad eye, you'll just use your good eye and your bad eye will get worse. Does the same thing happen with the ears?
No, not that we know of. No. But, there's been a lot of studies, and this is going away from the kiddies right now, but there's been a lot of studies of that if you don't aid people, that it's affecting cognition. And that is, if you think about it, the earlier the better, we say with everything. And that's only more, they're looking at it in the phases right now of adults and dementia, et cetera, and the cognition. But I have to start thinking we're going to start seeing things that say that we're not aiding children early enough. We're going to obviously you're affecting their learning in the classroom. You're affecting their social ability to socialize. If you can't hear what something else is going on in a conversation, you miss critical cues. Your pragmatics are necessarily not going to be that great either, because you've missed out on how to read a room based on what there might have been said. One of the saddest stories in my own life was that I had a hard time hearing the lyrics of songs. So I'd understand, I took piano for like 16 years. I mean, I definitely loved music, enjoyed it, thought I was singing words that were there, that not necessarily. And we were in a car and we were teenagers and my mom was driving and I started singing a song and everybody started to laugh. And they were like, what? That's not what the words to the song said. And I was mortified. And that's something we can certainly see with our little ones too, as they're developing like red flags. If you say something and they come out with something totally different back to you, red flag, they didn't hear what you said.
Right.
Acoustic cues are so close to each other, bed and bet. When we think about consonants in our language, there's only little things that from a P to a B make a difference. A T to a D make a difference. If you're saying one word and they come back with something else, red flag, mommy and daddy, that something might be going on that maybe not is sensory neural, but maybe might be conductive.
Right. I want to talk for just a minute because it's a whole other topic, which is central auditory processing disorder, because I keep thinking about that as you're talking. So how would that present different from hearing loss?
Actually, it actually presents very similar to hearing loss.
Mm-hmm.
So the thing about CAPD is that you have normal hearing. Peripherally, your hearing is fine. So it's almost as if after you get beyond the cochlea, there suddenly becomes a screen. And some information gets through the screen and some information does not. And so how it's processed in the brain is very different. Most of the testing that they do for CAPD can adjust for hearing loss up to a certain level. But most of the time, the kids these are the kids that you'll say they are not paying attention. They may have mishearing, that they come back and say something completely different. They have trouble following directions. You think of all these things, are red flags that I'm telling you about hearing loss, and you're saying to yourself, but you just told me, Dolores, that their hearing is usually normal peripherally. But yeah, they're the same things. The other things that they know about central auditory processing is a lot of the kids who end up having CAPD have a long history of middle ear pathology. So there is a connection. It's not a direct one-to-one correlation, but there's definitely some things in the literature that point in the direction that when you haven't had consistent cues over a course of your lifetime being given to you, that there is going to be some of this rewiring in the brain that might not be the best rewiring. And so that kids need, it's not an efficient way to process information. They haven't learned how to do it. I always like the analogy to the screen of, certain information getting through and others don't. And those same kids with CAPD in a classroom benefit from some of the things that we talked about. Speech, FM systems, they're being used for other reasons besides just a child sitting in a classroom that has a hearing impairment. Back in the early 90s, late 80s, there was something called the Mars study. And it was on a grant, and they put sound-field FM systems in classrooms, and they saw what it could do for the kids in general. And it helped everybody. I mean, boosting the signal to noise ratio is, it's really, really important, because then what's essentially being said by the person leading the group is getting above all that background noise. And we know the tons of background noise sitting in classrooms with kids, whether it's the fluorescent lighting, the hard surfaces, things that we would do for a hearing impaired kid. We're like, rug the rooms, make it less reverberation in the room. I always tell the parents, if you can, rug the kid's bedroom. When we talk about being in classrooms, I say, that nobody wants to hear it, put drapes on the windows. Anything that can absorb sound, extraneous noise, will make it a better hearing environment. My own house, I have hardwood floors in most of the house, but I have rugs in my family room and my living room, up in my bedroom. Why? Because those are places I really need to hear what's going on. I wish I could rug my kitchen, but because we spend a lot of time in there, but anything to absorb sounds to make it a better acoustic listening environment is really, really important.
Maybe that explains why I had carpeting in my kitchen when I moved into my house. I took it out.
You're like, why did they do this?
Brown carpeting in the kitchen. No. Can we talk a little bit more, now that we've been distracted by carpet in the kitchen, about speech, causes of speech delay? I don't know how much in detail we can go into. There are so many different subtypes.
There is, and we spoke.
And when you should be concerned, I always like to start with what is normal and what is not, rather than get everybody worried.
Everybody does worry. Right. Everybody does worry. My big thing is that you should look at overall communication. So when a lot of parents run to get tested for early intervention, only for people to hear that they don't qualify for early intervention. And I think and I taught our early intervention courses for New York State for the evaluators and for providers. And I would say parents here, we don't qualify as nothing's wrong.
Right.
And sometimes there really isn't anything wrong. Because I said, when we look at overall communication, it doesn't always mean verbal. You communicate by pointing. You communicate by gesturing. You communicate by sometimes pulling mom and dad over to what you need. And that's happening in the younger years. And it's supposed to happen in the younger years. Them making eye contact, them being able to follow simple directions. If you say ba, 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 they should be able to come back at you with a ba, 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 or something along those lines. That is typical. That is normal. When do we get that it's atypical? Well, when they're not making any communication at all, when they're not attempting to point, when they aren't attempting to gesture for something that they want, they completely. Not to say that terrible twos do not exist, they do, but their likelihood of having a tantrum because they can't communicate becomes much worse, because it's not only a matter that they can't verbally communicate with you, they can't communicate with you at all. By age 1, we're pretty much seeing 1 or 2 words coming in. I tell parents by 18 months, I start want to see 20 to 50 words verbally coming in by that range. By age 2, they should start put words together for you.
Right, but I'm sorry, but first of all, I want to have one point. I don't want to miss it in that there's different types of babbling we didn't really go into, and that all babies babble, whether or not they can hear, right?
Yes.
That's just they're making sounds, but when they can babble back and forth, that's what you're looking for.
Right, exactly.
Right. That was one thing. And the other is when you say, 25, 50 words at 18 months, so many kids are still within the normal range who can't do that. So I don't want people to all start asking.
Oh, no. There's a range.
Yes.
There's a range.
They're all coming to you otherwise.
No, I don't want them all coming to me. There's a range for everything. Just like we say, if the kid's not walking at 12 months, it's fine if he's still not walking at 12 months. He's got a range till 18 months for that.
Right,
to become
exactly.
So the same thing with speech. There's a range. And it's okay to be at the outer limits of that range. I think I want to bring up is if there always should be some progression.
Right.
So I think that's my big point I want to bring across here. So if we're seeing 1 to 2 words at 12 months, you should start seeing them progressively gain more words as they're getting older. Some kids will learn words faster than others. We see a lot of children who have older siblings and they're not big talkers. Well, why not? Because the siblings are talking for them.
You can't get a word in his voice. Yes.
Exactly. Especially in my family with me. So that's perfectly normal. And I'll say parents kind of have to tell the other kids to, stop talking for them. Give them a chance to communicate. So that's really, really important. Regression is never normal.
Right.
Never. And I think that's the other, we want to always see some sort of progression. Some might be little baby steps and some might be big jumps over hurdles, but you always want to see that it's going in an upward direction. Anytime we see regression, we know we have a problem. Then we have a big problem. Because
when you say regression, I want this to be right. When you say regression, I want this to be clear, because a lot of parents do say the child was using this word and then they stopped using that word. And now they're using a different word. And I don't think that's the same thing as regression.
No. So they had 25 words in their vocabulary, let's just say, as a toddler that they were using appropriately to label, to ask for something, and then all of a sudden it stops. They are no longer using that anymore. That's regression. And usually I'll hear that it's happening somewhere between 18 months and 2 years. That if they have regression, that's usually where it occurs. And that's something that we need to be really concerned about. And those are the kids that are going to be in that bracket of qualifying Not that there aren't other kids, but those that are significantly delayed or that come in that say that they have significant regression, those are the ones that are qualifying for the early intervention programs right now.
Right. I have to make a medical disclaimer at this point again.
Go ahead.
We're not here for medical advice, but that's the kind of child I want to see, at least the pediatrician, if not the neurologist.
Right.
Not just get early intervention. Don't think it's okay to just get early intervention.
No, that
is not normal. It is not normal.
And it's so
a number of possibilities. There could be seizures. There's a number of syndromes. There's so many things, and autism.
Right.
Not normal.
Not normal. And they usually are seeing their pediatrician before they're walking the door into us as well. Because there's tons of paperwork, and for good reason. We want to make sure that everyone's in the loop. You said before about a team approach. All of this is a team approach. And it's really, really important that the members of the team actually speak to each other. That's what brought me to you, right? That's how we met, because there was actually a reason that the speech language pathologist should be speaking to the pediatrician, that it was important. So that's definitely
so busy though. Right. I wish it happened more. We're so busy. So speaking of pediatricians, and I am one, so I don't want to be mean to pediatricians, but I'm sure you hear the parents say the pediatrician said they'll grow out of it.
Sometimes.
Yeah.
Sometimes. I'm trying to be careful. Sometimes.
I know, you're being very nice. No, because how does the parent know when to get evaluated? Well, they might go to their pediatrician and say, well, is it normal? Sometimes it is, and sometimes it isn't. Can we give some kind of guidelines without giving medical advice?
I know. And it's a toughie. It really is tough how I'm going to answer this. So I think the communication aspect is definitely one. Mm-hmm. I think them having, we talk about canonical babbling. If that suddenly stops, that they're not doing back and forth babble. If they can't imitate, let's talk about that for a minute, because that it lends itself. I see a lot of kids that receptively are intact, and now we're getting to a point, the 2-year mark, and they still have no words. And the parents will say, Dolores, he understands everything. So when you're at a point where you're post 18 months, where you should have like 5, let's give that range and say, well, 18 months, we really should have about 5 words or approximations. They don't have to be beautiful words. They can be approximations. That's perfectly fine. And so you're sitting there saying, okay, they don't. You're telling me by age 2, they should be putting words together, and that's not really happening either. Now I start saying, okay, let's look if they can imitate. If you say something, can they at least attempt to imitate what you're saying and get something close? If they're not doing that at that point, that's a red flag. If you're looking at them and they're trying to say something and their tongue seems to be all over the place, for lack of it, we call it groping to try to make sounds, that's a red flag. Some kids not only have that problem with the motor coordination when it comes to speech, some of them you would look at and say they have motor coordination in general that is happening, that they're having difficulties with, whether it be walking or moving or trying to pick something up that they just don't see coordinated. A lot of the kids who can't imitate sounds, a good portion of them, parents will say, they're really messy eaters, like really messy. And then I'll watch them eat and I'm like, well, that's because they seem to have very little motor coordination with their mouth on how they're chewing and moving food from side to side and swallowing. Those are the kinds of kids, like you say, those are the ones I want to see. Those are the ones that I want to see, because any, problems with motor planning lend itself to not developing speech quite readily. Those are usually kids that we need to have an intense amount of therapy for, that have motor planning problems.
Right. So when you say motor planning, you're talking about oral apraxia at this point, right?
Yes.
And I do see that, and I do want to emphasize that either if you see this, right, even if your child's getting speech therapy, not making progress,
right.
I do see this, and then I really do want them to get evaluated specifically for that. Who can do that oral apraxia evaluation?
Somebody who's prompt trained or prompt certified. It's something right now that is recognized. There are people that have a heavy background that aren't prompt certified, but who have worked years in apraxia. That's their. I tell people all the time. There are certain speech language pathology is a wide profession. We see children, we see adults with many different disorders. Like you and I said, we can sit here forever with the amount of, the amount of disorders that we see and different types of language issues. But I would never say that I'm proficient in stuttering. You don't go to somebody who their wheelhouse, their thing is stuttering if you suspect that your child could have apraxia. You want to look into a speech pathologist who has a significant background working with that particular population, because it does take somebody well-trained. It is something that they're not going to grow out of, like we had that discussion. They're going to need intensive therapy by a professional who that is what they do. And I'd like to think that my field, we picked on a little bit the pediatrician that says that they're going to grow out of it. We could pick out, people in every profession that says, oh yeah, I can handle that.
Right. You have to know what you know, what you don't know. Not everybody knows that.
Right. And you got to be able to say, I need to refer.
Right. But the parent is the child's best advocate. And if the parent is saying, oh my gosh, my kid's been in speech therapy for many months and is not making any progress, then that's the time to think about it.
Right. Absolutely. I really feel that, like you said, parent best advocate. And there comes a time where you're going to go with your gut. Like, things aren't moving. I don't understand why things aren't moving. It's time for a change. It's time for me to look at something else. To see what I can help. And there's, I try to stay away from telling parents to go down the Google minefield, because there's so much misinformation on the internet. But there are certain groups that are appropriate. Certainly, the American Speech Language and Hearing Association. If you go, that's our national organization. If you go up on that website, and they'll have red flags for apraxia. They'll have red flags for autism. If you go on that site and you're there as a parent and you're saying, I'm checking off almost every single thing that I see, well, then it's time to have your child evaluated in a, with a different mindset.
Right. And autism actually is comorbid, not infrequently with degrees of apraxia.
Yes.
Right? It's not either or.
Yes. And we talked about that even with the hearing loss, the comorbidity, especially with autism. And it's really important. And, as we're treating the child for the apraxia and we're using all these methodologies that have, that are data driven, I think it's important to tell parents that you need to go to somebody who's doing a methodology that has, research behind it. It's not, that we're waving magic wands. I wish it was that easy. As we're doing all that, you have to make sure that your child has a means of communication. And I think that's sometimes where we fail, because it might take a while for them to be able to develop all verbal language. And what are we doing in the meantime? So that's where other methodologies like a picture exchange system, you're going to hear PECS, comes in. I work a lot with assistive technology doing AAC evaluations. I'm not saying you run to it with your 2-year-old, but when the child's getting close to that 2.5 mark, look, if they can sit there and get into YouTube on your iPad.
It's true.
It's true. It's true.
The cognitive ability is there.
And that is what drives a lot of this. cognition being intact. But my point is, you can't wait for them just to develop that other verbal piece, because we don't know how long it's going to take us to get there. And
right. What about sign language?
Absolutely. Except that with sign language, so I'm going to say two things about sign language, because I'm a big proponent of it. Is one, if they have motor coordination, sign language could be an issue. If they have motor planning issues and it's global, sign language could be an issue. So, but I always tell parents in general, and you'll see like these little videos, they have a baby talk and the parents using sign language, baby sign. That is amazing. There's research that says that teaching your child sign language actually promotes verbal languge. So I'm all for it. The one thing I will tell parents to steer clear of, that's I will tell teachers and I will tell other therapists, is teaching your child the sign for more. Why don't you? Yes. Why do you not want to teach them the sign for more? Because when normal development, a baby just doesn't go around saying more, more, more. In normal language development, they're labeling. You want them to learn vocabulary. So more what? If I sit there and go more, you have no idea what I want. But if I say appa for apple, or I say ba for ball, you know what I'm talking about. So, us going around with a kid going more what? And if you're going to teach more, you better teach the object that we're talking about. More food, more apple, more nana, more what? More toy, more ball. It's, and when it comes to apraxia, it could be a pretty easy sound that they're developing, but you don't want it, because it's really stunting their growth in language in other ways. Does that make sense?
I think so. It was like the first sign my daughter learned, so I'm shocked.
Well, but you're learning more, but then you're adding other things to it. You're not sitting there with them just learn. And I think people get stuck on this piece that we just teach them the word more. Whereas, you want them to develop other words.
Well, if you keep reinforcing them more because you're so excited they're doing it, then they're stuck there.
Exactly.
Got it.
Exactly.
Wow.
Exactly.
I did not expect that. I did not.
Sorry.
Okay, I'm going to throw you something else that I didn't tell you about beforehand. What about facilitated communication?
Not a fan to that one. Not a fan. You know how I've kept on saying data research?
Right.
You heard all those things. Yeah, not really. It's a no-no. It's a no-no in our
field. That's because?
There's not enough to support evidence-based practice. And
right. I mean, I think what I understand about facilitated communication is that in most, not all, but in most of the cases, the facilitator is the one doing the communication.
Right. Exactly.
Right. It's become, unfortunately, very controversial. There are, people who've been, graduated college with degrees with facilitated communication. I have heard that some do actually have such severe motor planning that they can't control the fine movements, but they are literate and they are doing it. So I think there's always an exception to the rule, but you don't want to promote something that
no, I don't.
Exception to the rule, it works.
Right. And ASHA really has come out against it. So you know what? And in fairness, I really want to say this in fairness. I think most people have their ethics in the right place. They have their heart in the right place. And I think sometimes you prompt and you don't even know you're doing it.
Right.
I recently got my prompt certification to work with kids with apraxia. And part of that certification is that you're videotaping yourself. Oh, yeah, I'm not good. I talk with my hands. I'm not really, but it is a learning experience because now you're watching what you're actually doing. And I was like, oh, why did I do that? Oh, I'm not prompt in the capital PROMPT, but in the lowercase, I prompted something that I didn't even really want to prompt. And I'm like, oh, you kind of do it and it's incidental and you don't even mean it.
Unconsciously, right.
Yeah, it's unconscious. So I don't want to say that everybody is doing it purposefully to make them look like, this kid's glowing, when they're not. And just a little bit in general, when we say facilitated communication, I'd rather see them see assistive technology,
right,
which is really coming out there. I mean, like we said, we've come so far in so many different areas. And being able to use what's out there, use a switch, being able, to hook up things. I mean, look at Stephen Hawking. I mean, there are ways of doing this. There are eye gaze for those that are really, really impaired, who need a way to communicate. It's out there. And, you threw me the FC ball, but I'm not playing.
Good job.
I'm not playing. But like you said, that they're literate, that they're so severe in motor. You want them to be able to communicate.
To truly communicate, right.
To truly communicate, not somebody else's feelings,
right.
not somebody else's thoughts on what they think they want to say. I really feel that assistive technologies come far. I think we're going to come further. And that's where we need to put our balls in that basket right now. That's where.
How young can children get assistive technology?
Well, it depends. There's low tech and high tech.
Mm-hmm.
So when you talk iPad, it's high tech. When you talk
right.
Dynavox, it's high tech. When I'm talking about them being able to pull, a storyboard, a picture board, or PEC situation where they're pulling off a picture and handing it to you, so they get this idea that, oh, wait a minute, if there's a picture of a chip and I give it to her, I suddenly get that chip that's across the table. You can start that really young. You could start that 18 months, 2 years, as long as they've got the coordination to do that. And they have to be able to discriminate. I mean, PECS it's complicated. It's not as simple as just doing, picture exchange. But yeah, you can start younger when it's something like that. The high tech stuff is later. It's later. I wouldn't be doing that, for somebody until they're probably around 3. But you've got to get them to communicate and, point. We always start with pointing, that's usually the first thing. And then develop all these other things as we go for these learners, because like I said, especially the kids that we talked about that, the apraxia situation, we want them to be able to communicate. That should be the number one priority of any speech language pathologist. I know for parents, the number one thing is I want to hear my child's voice. I get that. But while we're waiting for that to come in, and you're working with every professional and you're working as a team and we're trying to get that to happen, I need them to communicate. I need to make sure that we don't have a breakdown in communication.
Right. They need to communicate.
Right.
Right. Children get very frustrated when they can't.
Right.
So
right.
That's really important.
It is. And that's part of the terrible twos. There's a lot to say about that. And I just had a friend on the phone and was like, oh, he's so into the terrible twos. And I'm like, it's appropriate.
Right.
It's appropriate. I said, they want to say so much more than what their ability is, to do so at this point. I said, so yeah, you're going to get a run for your money for a little while. I said, it'll be okay. I said, he'll come around. And I said, I don't think you're going to forget them, but there'll be a distant memory. And there'll be a distant memory.
Right. And that's also, we're not going to go down this path of the developmental disfluency or the temporary stutter that some children have. But I will say that I did an entire talk with a fluency expert, I forgot to tell you, with a fluency expert on stuttering. So I've already covered that entire topic. If a parent wants to know, is it normal for my child to be stuttering at the age of 2? It might be. It might not be. Listen to that talk. So
that's great. I wonder if it's somebody I know.
I'll tell you later.
Okay.
Anyway, we could talk, as you said, we could talk all night, but we're going to stop here and possibly reconvene for another talk about the topics we didn't get to, if that's okay with you.
That sounds fine.
But thank you so much. This has been so much amazing information, and I really, really appreciate it.
No, it's been a pleasure. It really has.
Thank you.
Bye.
Thanks for listening to the JOMA Preventative Health Podcast. If you've enjoyed this, please rate and review us on Apple Podcasts and share this with your friends. For more information, check out our Instagram at joma_org. Check out our website, www.joma.org, that's JOWMA.org, or email us at health@joma.org.